Hello, this is Harry Aslanian. It's a great pleasure and privilege to speak to you today and to honor the memory of Dr. Raffy Hovanessian. Today we're going to talk about optimizing colonoscopic PolypResection. It's the identification and particularly the resection of polyps at the time of colonoscopy that allows colonoscopy to prevent colon cancer. Not all colon cancers are prevented after the performance of colonoscopy. Studies of interval cancers have shown that those that develop after a colonoscopy are 2 to 3 times more likely to be sessile and to be located in the proximal colon, to be of smaller size, and that 30% of interval cancers occurred at previous polypectomy sites. Sessile serrated polyps can be very hard to identify and resect completely. They can be recognized by the presence of a mucus cap shown here. They are typically very pale, sometimes even less pale than the surrounding mucosa. They have a nondescript pip pattern and a slightly bumpy surface. You can see the edges of this flat polyp defined by these arrows here. To help identify these polyps, it's helpful to rinse off adherent bile during inspection. If you see an area of bile that's adherent after the water rushes over it, this may be the only indication of an underlying sessile serrated polyp. I find that having a clear cap on the scope can be very helpful to see behind folds, and it's been shown that taking a second look in the right colon where these polyps are more common, or retroflexion in the right colon may aid in detection. Incomplete resection is common, and to maintain the effectiveness of colonoscopy in preventing colon cancer, we need to not only find polyps but remove them completely. For polyps that are increased in size to 1 to 2 centimeters, incomplete resection occurs in about 17% of resections. And for sessile serrated polyps, rates are even higher at 1/3 to 1/2 of all resections. In this talk, I hope to outline the optimal steps for the performance of endoscopic mucosal resection. We'll look at lesion characterization, the tools that will help in the performance of EMR, preparing the lesion for a resection, the steps involved in resection, and complication management. EMR is effective for 98% of patients. However, a large number of patients that could be endoscopically resected are still undergoing surgery. Surgery is associated with increased morbidity, with approximately 1% mortality and 15% rehospitalization. Thus, it's ideal to optimize the EMR techniques and offer them to the greatest number of patients possible that would benefit from colonoscopic EMR. In preparing for colon EMR, the pediatric colonoscope is the ideal tool given its increased flexibility and maneuverability. A clear cap on the scope is very useful to stabilize the scope and provide some distance from the lesion. Carbon dioxide is very useful to use for insufflation over air in the event that there should be a temporary perforation that you can most frequently close with through the scope techniques. It's important to discuss with the patient that the procedure has a greater risk than routine colonoscopy, which we often say has a 1 in 1,000 risk of bleeding or perforation. However, with the resection of large polyps, there's up to 5 to 7% bleeding risk for sessile polyps over 2 centimeters and approximately a 1% perforation rate. It's also helpful to mention to the patient that a second colonoscopy to reassess the resection site after approximately 6 months is recommended for piecemeal resection of polyps over 15 millimeters in size. I also mentioned to the patients prior to the procedure that if we identify features of the polyp that clearly favor a surgical resection, then resection would not be pursued. These include signs of submucosal malignancy and extensive involvement by the polyp of the terminal ileum or the appendiceal orifice. Appendiceal orifice polyps that involve greater than 50% of the circumference of the appendix or have deep involvement into the appendix and you can't see the base of the polyp would benefit from referral for surgery. In preparing a plan for resection, we want to determine the polyp's borders, the likelihood of submucosal tumor invasion, and the likelihood of underlying areas of fibrosis that may complicate resection. Let's take a brief look at some of the classification systems that help define the characteristics of the polyp and help define our resection plan. These include the Paris classification, the surface pattern descriptions as granular or non-granular, and the Kudo-Pitt pattern. The Paris classification defines the shape of the polyp as being polypoid, slightly raised, sessile, flat, or depressed. The Kudo-Pitt pattern can differentiate the histology of polyps between hyperplastic polyps and those that are adenomatous. Hyperplastic polyps tend to have a smooth surface and very circular, regular pits, and adenomas tend to have more of a brain-like pattern on the surface. Laterally spreading polyps can be defined as granular or non-granular. Granular polyps have a bumpy surface pattern that indicates a low risk of fibrosis. These polyps typically lift very well with submucosal injection and are well suited to EMR. Laterally spreading tumors that have a smooth surface are termed non-granular. These have an increased risk of fibrosis, and it's important to assess for areas of depression that may indicate underlying high-grade dysplasia or possibly cancer. If you identify the loss of a pit pattern or vascular pattern in an area of ulceration or depression, this suggests submucosal invasion of a tumor. In these cases, it's advisable to biopsy the lesion and forego EMR and refer the patient to surgery. In many cases, these lesions are also associated with a non-lifting sign, which is where with submucosal injection, you see failure of the polyp to lift up. This is a sign of submucosal invasion or can be a sign of prior manipulation of the polyp with prior attempts of resection and may also indicate fibrosis from prior resection attempts. After completion of EMR, when you receive your pathology results, it's also important to be aware of findings that would indicate a higher risk of lymph node metastasis that would require consultation with a surgeon and or tumor board. These pathologic findings include lymphovascular invasion, the presence of histologic high-grade carcinoma, a positive deep margin, tumor budding, or deep submucosal invasion. To begin resection of the lesion, we want to position it in the 6 o'clock position and think about repositioning the patient if necessary so that fluid accumulates away from the lesion. We want to prepare to initiate the submucosal injection with a blue injection fluid. This can be a combination of saline and methylene blue or a commercially available, more viscous solution. When performing submucosal injection, we ideally want to bring the lesion towards the scope and lift it away from folds. This is usually accomplished by injecting the more distal edge of the lesion. As we inject, if you pull back on the catheter and take some pressure off the lesion, that will allow you to see how much lifting you're accomplishing and adjust the needle as necessary. These photos demonstrate how the blue injectate lifts the polyp away from the muscularis propria and nicely defines the borders of the polyp. After resection, The submucosal fibers are highlighted, which allows you to assess for any signs of wall injury and helps determine if there is residual polyp left at the base. In selecting a snare, sessile serrated polyps are ideal for resection with a cold snare as they're very thin and have low vascularity. Thin sessile adenomas also are well suited to cold snaring. As you encounter thicker sessile adenomas and polypoid polyps, a hot snare is required. In planning your snare motions, it's useful to plan to resect a few millimeters of normal tissue at the edge of the lesion, and as much as possible to follow the resection edge to avoid islands of tissue left behind. After each resection, it's useful to inspect the mucosal defect, and to often you can spray some water with your foot pedal, and you want to look for residual adenoma, any signs of wall injury, and underlying vessels that may be prone to bleeding or have started bleeding. Dedicated cold snares have been available for several years. These have a very thin wire without cautery capability. They're very good at grasping very flat polyps. Often that cannot be grasped with any other tool. They're very good for sessile serrated polyps and flat adenomas, and they're also very effective for sessile adenomas in the duodenum with very low rates of delayed bleeding and perforation. This video demonstrates cold snare resection of a very small polyp. The main difference between hot and cold snaring is that with cold snare, you want to maintain a constant downward pressure against the tissue when resecting. Here are some tips for using cold snare for the resection of large sessile polyps. Each individual cut is the same as you would perform for a small polyp. Small oozing is expected. You can use the water pump after each resection to clear the field, and often you'll see the submucosa expand as it can contain the water once it's open. You want to plan to resect a margin of normal tissue, and like we talked about, you want to push down onto the tissue, sometimes even maintaining a slight torque to keep the downward pressure of the snare against the tissue. If too much tissue is contained in the snare, it won't cut, and you can remedy this by opening up the snare, lifting up slightly, regrabbing less tissue, and then obtaining a cut. After larger cold snare resections, you may see these whitish submucosal cords in the resection base. These require no biopsy or treatment and are just bunched up submucosal fibers. This video demonstrates cold snare EMR of a 5 cm right colon sessile serrated polyp. Here we're seeing the very subtle pale sessile serrated polyp with somewhat of a mucus cap. As we inject the blue injectate into the submucosa, it helps define the borders of the polyp, and by pulling the catheter away, we're able to see the degree of lifting that we're achieving and making sure we're in the right submucosal plane. Here we're separating some of those folds some more. Now that we have the lesion lifted, we can begin resecting with a cold snare. We get our first cut by pushing downward, and then we'll move to the next spot, moving along the lateral edge, getting a few millimeters of normal tissue and leaving no intervening tissue if at all possible. Spray some water to maintain the field of view and inspect each cut. Now we're laying the snare down at the next spot, kind of working along the edge of the resection margin and giving that downward pressure to maintain the cut and maintain the snare where it's been placed. Sometimes a little bit of torque will help maintain that downward pressure and achieve a cut. Now in inspecting the base, there's a few millimeters of residual tissue that we can also remove with the cold snare. And even with hot snare resection or previously resected polyps, I find cold snare to be very helpful to work in these more difficult areas. And then lastly, we'll ablate the border with a hot snare with just a little bit of the tip of the snare out and the soft coag setting, and we can ablate the borders of the polyp. You can also ablate any islands of tissue at the base. I find it very helpful to switch tools as needed to complete the resection. As there's smaller and smaller areas left, or some areas that may have fibrosis or that are very flat, changing tools can be very helpful. Moving towards a cold snare, like we talked about, after using a hot snare can be helpful. Jumbo biopsies can then be very helpful if the cold snare can't grab the tissue. And then I find soft coagulation with the snare tip, like you saw, to be very helpful for additional small areas at the base or at the edges. Multiple studies have shown that snare tip soft coagulation of the lesion edges significantly reduces recurrence of the polyp. One study found that residual polyp at the 6-month colonoscopy after resection of flat polyps over 2 centimeters had residual polyp in 21% of controls versus 5% of those lesions that had the edges ablated. Some recent studies showed high rates of residual polyp at the initial 6-month evaluation in large sessile serrated polyps that were removed with cold snaring. Although there's small areas of tissue that can usually be easily removed, I think the biggest change that we've seen in our technique is that we're much more likely to ablate the edges and the base of larger sessile polyps that we remove with cold snaring. And this is shown to be very safe without any increases in adverse events. I typically approach managing adenomas within areas of scarring in the following sequence. I usually try submucosal injection first, although there's often limited lifting due to the scarring, but this can help define where the areas of scarring are most prominent. I would then remove as much of the tissue as possible with a cold snare, and this can often be quite effective. There's usually some additional scarred areas that are non-amenable to cold snaring, and I would clear those out with a jumbo biopsy. Often at this point, there's just a little bit left that can be ablated with a snare tip soft coagulation. If there's larger areas that require ablation, you can use a soft coag ablation with a closed coag grasper. Some more complicated techniques are also listed here. Bleeding during EMR resection is fairly common. This is often readily treatable with the snare tip soft coagulation. Larger vessels can be treated with the coag grasper, which is essentially a hot biopsy forceps with this smooth jaw so you don't rip the vessel after grasping it. Delayed bleeding may occur in up to 5 to 7% of larger right colon sessile polyps. Several studies have shown that clipping the mucosal defect after resection may reduce the rate of delayed bleeding down to about 3%. In particular, you might want to consider clipping the defect in patients who require resumption of anticoagulation, and if you have any concerns for the presence of a delayed perforation. Perforation may occur in approximately 1% of cases, and when recognized during the resection, this can frequently be treated with endoscopic techniques, including through the scope clips and over the scope clips. Suturing can be used typically only in the rectum due to difficulty passing the device beyond this area. Here's another example of the target sign, which is the white circular defect indicating a perforation, which can be seen on the lesion as well as the wall of the resection site. In summary of the EMR techniques outlined, you want to use a pediatric colonoscope with a cap and CO2 insufflation. Utilize digital chromoendoscopy to define the characteristics and the borders of the polyp. Assess for submucosal invasion before beginning resection. You want to plan your lift and your removal. Change tools as needed between hot snare, cold snare, jumbo biopsy, and soft coagulation. You want to plan to complete your polypectomy at one session if at all possible, and then bring the patient back within 6 months to assess for complete resection of larger polyps. Additional techniques that can improve outcomes with EMR include the use of a blue injection submucosal solution, the application of dedicated cold snares, the performance of snare tip soft coagulation for the margins and base of the polyp, soft coagulation hemostasis with a coag grasper, and performance of tattoo marking distal to lesions that require additional inspection or may require surgery in the future. Thank you very much for the opportunity to speak on this topic today, and hope we can meet in person in the future. Thank you.